And welcome back to part 3 of the chapter on circulation. We had just finished going over the renin-angiotensin-aldosterone system. There's a little bit more to talk about with blood pressure, and then we're going to finish up the chapter looking at capillaries and veins. So to finish up our discussion on blood pressure, let's go to what happens when we have extraordinarily low blood pressure. This is a phenomenon that we call shock. State of very low blood pressure can result in people losing consciousness. There's inadequate organ perfusion, and this can be deadly. There's lots of different reasons that it happens. You can read them. I'll go over it on the next page too. But basically it's this: generalized loss of vascular resistance. And it's due to, it can be due to a loss of blood volume or loss of pressure. Initially, the autonomic nervous system can kick on, the sympathetic nervous system telling the heart to beat faster and harder. It can also cause vasoconstriction. There's some endocrine compensation, so vasopressin can get released. However, if treatment is inadequate, if the response is inadequate, and then especially if you can't resolve what's the underlying cause of the problem, the late decompensation has high mortality. People do not recover sometimes from shock. So let's look at the different causes of shock. So on the left, I have the actual name of the kind of shock. And then over on the right in parentheses, I put it in the simplified terms: pump, tube, liquid in the tubes. All right, so the first one, hypovolemic shock. The name tells you it is low volume. This results from hemorrhaging or severe dehydration. And when I say severe, I don't mean I'm a little thirsty. I mean like diabetic ketoacidosis. The patient is so hyperglycemic that the kidneys are losing. There's all this glucose that's spilling into the renal tubules that's drawing lots and lots of water into the renal tubules. So the patient is peeing out enormous volumes of urine. It's just dehydrating the circulation, and then that's drawing fluid from the cells. This is very low volume. So the problem here is liquid in the tubes. The amount of liquid in the tubes is way too low. Okay, and so you can try to compensate. The heart rate's going to increase, and the constriction in the blood vessels going to try to compensate for that. Another kind of shock, distributive shock. This can be due to lots of different reasons. The one, well, you'll understand this because we've already talked about the immune system. Remember we said if somebody has bacteremia, the infection has reached the bloodstream, they can become septic. And recall, huge amounts of histamine are being produced, and histamine is a vasodilator, and it makes the capillaries really leaky. So we lose pressure because the blood vessels are dilating, and we're losing some fluid because it's going into the tissues. This can happen in response to infection, but it can also happen with an overreaction of the immune system to an innocuous stimulus. This is what we call anaphylaxis. The examples I think we talked about were peanuts, strawberries, some shellfish for some people. Also, we can get this relaxation of the tubes in neurogenic shock. Recall, if you will, that the sympathetic nervous system is the part of the nervous system that has to stimulate the blood vessels to constrict. And if there's a lesion in the spinal cord and we can't get information up the spinal cord about blood pressure, we sometimes lose blood pressure. We don't get the sympathetic nervous system stimulation out to the blood vessels to get constriction. This is neurogenic shock. Okay, so what we're talking about here is the tubes. We're not getting them to contract enough. I put in parentheses and the liquid in the tubes because in septic shock, you have those extraordinarily leaky capillaries, so that just makes the situation worse. Okay, cardiogenic shock, as the name suggests, cardio, the heart, genic, generating the problem. So it's the pump. This would result from, say, severe myocardial infarction. We have acute heart failure. There's some occlusion in the coronary arteries. We're not providing oxygen to the cardiac muscle. No oxygen, no ATP, no muscle contraction. So there's a rapid decrease in cardiac output. Kind of related to this, obstructive shock. Now, the heart itself is willing, it's trying, but there's something interfering with the pump being able to move the liquid in the tubes. So there can be an obstruction, for example, to the blood leaving the heart, as in the case of a pulmonary embolus. Remember the right side of the heart, that's the blood that's going to be right back. So it's supposed to exit the right side of the heart and it's supposed to pump out to the lungs. Well, if you had a blood clot in one of the legs and it dislodged and came up through the heart, it just came in through the right side and then it's coming out through the right, or from the right side out to the lungs, it can get stuck as the arteries get smaller and smaller, and it can obstruct blood flow. Also, we can have obstructive shock in the case where we're restricting blood from entering the heart. For example, if we have cardiac tamponade, so there's fluid building up around the heart, and so it's being compressed because of that extra fluid on the outside of the heart, so we can't expand to fill with fluid. That is also going to result in obstructive shock. But the point is, all of these are resulting in a huge decrease in blood pressure, and unless it can get resolved and resolved quickly, this can be a lethal condition. And these are all covered on page 304 and 305. Now we are transitioning back to looking at the blood vessels. We already took a look at the large arteries and the arterioles. Now we're going to look at capillaries next, and we'll finish up with veins. So the big property of capillaries is that they're permeable. The stuff is going to be passing very slowly. This is where we're going to get exchange. There are some different kinds of capillaries. We're not going to make a huge big deal out of these, but most of the tissues have what are called continuous capillaries, meaning the cells are actually touching each other. These endothelial cells are touching each other all the way around. But stuff can still slip through between the tight junctions between these cells, as well as we can have diffusion through the cell membranes. We can have active transport through the cell membranes. And so, yeah, wherever we have capillaries, we're going to have some exchange of material between the blood, the circulatory system and the tissues. In passing, I'll just mention in some parts of the body, we have different kinds of capillaries. Basically, the endothelial cells are there are more openings. I hear my kid coming, so you may see her show up, possibly. Brinley, here she is. All right, say hi. Hi. This is a recording, sweetheart. All right. This is my little one. So we're going to keep talking about capillaries. So we have fenestrated capillaries. Fenestra is a Latin word for window. So there are these openings in the cells, and stuff can pass through. We'll see these in the kidneys, GI tract, glands, where you're going to have a lot of exchange of material. And then discontinuous, these big openings between the cells. This we see in the liver. All right, now let's take a look at the flow, both through the capillaries and across the capillary membranes. It's a balance between forces pushing out of the capillaries and forces pulling into the capillaries. On the left, we have the arteriole, on the right, the venule. In between, this is a capillary. There is no significance to this box other than I was trying to cover up the words and the numbers that were in here to simplify things. This is the best I could match the colors. That's all that box is. All right, so at the start of the capillary, here at the arterial end, or here, there's more pushing, there's more force pushing out of the capillary. So we have higher capillary hydrostatic pressure. Fancy way of saying there's more pushing, more stuff coming out, represented by these big arrows. So the net effect is stuff's going to leave the capillary and go into the tissues at this end. At the other end of the capillary, so I guess we're calling this the start of the capillary and this is the end of the capillary, there's more pulling, if you will. There's stuff being drawn back into the capillary. This is because we have higher capillary oncotic pressure. A reminder, the term oncotic, it's a subset of what's referred to as osmotic pressure, but oncotic pressure refers to the power of the proteins that are dissolved here in the blood to draw water back in. So this is primarily the job of albumin, is going to be drawing the fluid back from the tissues back into the capillary as it approaches the venule side of things. That's the way it's all supposed to work. So the net pressure, meaning, adding all of these forces together, which way is stuff going to move? At the arterial end, we're going to get what's called filtration, which is the term that means stuff leaving the capillary and going into the tissues. And then at the venule end, we're going to get reabsorption, which is the term used for like the net effect is we're going to have more stuff coming in back into the capillary at the end. So continuously, we have fluid that's leaving the capillaries and washing over the cells of the tissues, dropping off oxygen, dropping off other nutrients, picking up carbon dioxide, and picking up waste. There's always a little bit left over, and that little bit that's left over, that excess, is absorbed by something called lymph vessels, the lymphatic system. Let's see if I can show you a picture. Here we go. All right, so the lymphatic system, blind-ended capillaries means this is not a system like, how with we've got the pump and you got the tubes, and the tubes go directly from the heart all the way around and then reconnect to the heart at the other end. Okay, this is a little bit different from that. These tubes, if you can think of it as starting at capillaries, and then they get wider and wider and wider, bigger and bigger and bigger, and feed back into the blood vessels right before the blood is returned to the heart. So we've got these blind-ended capillaries, meaning they're not coming from the arteries. They just kind of start in the tissues. And they have permeable valves, things, push doors, if you want to think of them that way. Things can get in between the cells. So they collect the fluid that's left behind in the tissues by the capillaries. It's normal. This is just normal. They drain back into the subclavian veins before that goes into the superior vena cava, returning the blood to the heart. The normal flow, the whole system, 2 to 4 liters in a day. It's pretty low volume. It's pretty slow flow. Ooh, actually, this is a good time to remind you. Remember the immune system? We've got those lymphocytes, and they hang out in the lymph nodes, and the stuff is passing through them and being shown to them. This is how it can be presented. The macrophages and the dendritic cells can present their stuff to the T lymphocytes because things are moving really slowly through here. I think of these like the police checkpoints, when they're checking for drunk drivers. They don't stop, the highway movement. They stop traffic on the smaller roads, and they have the opportunity to check individual drivers. So okay, this is that part of the system. Why did because look, it's not huge volumes the way the the rest of the circulatory system is. But if there's a a problem with flow through this area, 2 to 4 liters, like this stuff adds up. You know, you can get some swollen areas with lots and lots of fluid in them if this system isn't working correctly. All right, so let's talk about that. What we call edema is having too much fluid in the tissues. So this is a result of an imbalance between those pushing and pulling forces, remember, pushing out of the capillaries and pulling back into the capillaries. This can result in edema. So it can result from hypertension. For example, the hydrostatic pressures inside the capillary pushing out are going to be really, really high. That's what I mean by up pushing, meaning an increase in the pushing out from the capillaries. It can also happen if we have low pulling, so low plasma albumin, such as in the case of somebody suffering from liver damage, or hyponatremia. They have too much water and not enough salt in the system. Honey, I'm going to be done in a few minutes. Okay, I'll be there in a few minutes. So both of these, low protein levels, having too much water on board, not enough electrolytes on board, these can both result in swelling. Okay, this can also happen, the swelling can also happen. The capillaries may be fine, everybody's, you know, electrolyte balance is fine. The problem could be in the lymphatic system, the drainage, and this can happen because we have blockage, for example, with a tumor, or a surgical excision of a tumor. And so there's vessels that are just missing from an area because somebody had, for example, a mastectomy and had lymph nodes in the area removed. That's also going to remove the lymphatic vessels. Okay, so the end result is extra interstitial fluid and high tissue hydrostatic pressures. So we have extra fluid in the tissues. All right, now we're going to get into the veins. We just wrapped up capillaries. So structure of veins, these are thinner walls than the arteries. They're more compliant, meaning that they can expand more. They're easily deformed. They can change shape due to volume or pressure load. The leg veins in particular have to work against gravity to return the blood back to the heart. Remember, we said the pressure increase and decrease with the heart rate, and then it goes lower and lower and lower, and then we lose the pulsatile nature, and then the pressure is just really, really low. So it doesn't, the blood no longer has enough oomph to get back to the heart. And so we rely on skeletal muscle, the muscle pump of leg activity. So walking, for example, helps to massage the deep veins, to milk the deep veins, push the blood up. And this is, you know, if in the absence of the muscle pump, actually in paralysis, or if somebody's immobilized due to a cast or they're after surgery, this is one of the reasons we want our patients up and walking. This is where a lot of our blood clots form because of the stasis, the circulatory stasis. All right, other venous dysfunctions, genetic influences on valve competence. So veins, unlike arteries, they actually have one-way valves. So if the muscle contracts down here, you know, the calf muscle, say, and it pushes some of the blood up, we don't want that blood to back down into the feet again. So there are these ways of kind of catching the blood. So they're one-way doors. The blood pushes up and then it's not allowed to go back. Employment, yeah, jobs like being a pharmacist, being on their feet all the time, but not walking a lot. Nurses walk a lot. Teachers on their feet a lot, working in the post office, any kind of job that like has you on your feet, but you're not moving very much, allows blood to pool. During pregnancy, the blood volume increases dramatically. And with obesity, we also have large blood volume to deal with. Let's review a little bit of leg vein anatomy. There are superficial veins and there are deeper veins. Let's what we call varicosities. They can form in the superficial veins. The pressures dilate the vein. They cause the vein to widen. That changes the shape of the valve. The valve can't close anymore. I mean, the blood can push it open, but then they don't meet anymore. The two flaps don't meet anymore, and so the blood can pass back. And so you get this increase in pressure, back pressure, and that causes the vein to change shape. The vein actually grows to accommodate this extra force, and so the veins can become quite tortuous, leading to venous hypertension and further distorting of the vessel. Okay, and yeah, the superficial vessels are supposed to drain into the deeper ones. And now we transition topics to pediatric disorders of circulation. The biggest problem we see is hypertension, and it's becoming more pronounced. In the general population of children, kids without obvious risk factors, we see about 3% of kids showing hypertensive blood pressure levels. And the expected level for kids is going to be smaller based on their smaller size. There's less friction. So blood pressures are going to be lower, but they're still too high for that child's age and size. If, however, you narrow things down and you're just looking at kids who are showing type 2 diabetes, so they're showing hyperglycemia, then the number goes up to 10% of these kids are showing hypertension with all of the complications that come with hypertension. So this needs to be managed because they're going to be dealing, I mean, they'll have the one heart for the rest of their lives, and we need to protect it. All right, so routine visits should include blood pressure checks starting at 3 years old and up. All right, now we're going to transition to other age-related issues, but now older populations. All right, so we've got endothelial dysfunction. Endothelial cells, remember, lining the inside of the blood vessels. They're the ones that, when they're exposed to the shear stress, produce nitric oxide and prostacyclin. These cells are not producing as much nitric oxide and prostacyclin, so less vasodilation and more clotting. With age, we also get more vascular stiffness, or otherwise known as arteriosclerosis, which means we lose the vasodilating capacity. Remember how we said the blood vessels have to kind of incorporate all these different signals and come up with some kind of compromise amount of constriction? Well, as we get older, we have more vasoconstrictors than we have vasodilators, which ends up leading to systolic hypertension, which of course has consequences for the heart, which has to fight against that higher pressure. We also see more increased likelihood to develop aneurysms. So the elastic arteries, those are the ones that we're supposed to expand when the heart beats. We're supposed to get that expansion, and then the recoil when the heart relaxes. Well, instead of having elastin, we have more collagen replacing the elastin, which is less elastic. And we end up having more like breaking and bulging out instead of just, expanding and contracting. That's a bad way, expanding and recoiling. We see greater prevalence of vein disorders, not just the arterial problems we just described, but problems with venous insufficiency, venous ulcers. So in general, recommended changes, behavioral changes for our older patients. Of course, smoking cessation is step one if the patient is still smoking. And an increase in physical activity does help with the movement of the blood through the body. Because hypertension is such a common problem, many of our older patients are going to be, their hypertension is going to be managed pharmacologically. And we will wrap up this third part of this lecture with a review of pressure management. And we're going to simplify it again in this super streamlined version of the circulatory system. We'll remind you, we have a pump, we have tubes, and we have liquid in the tubes. And we can manage each of these. Each of these plays a role in the overall blood pressure of the patient. So if we're going to manage the pump, there are medications known as beta blockers and calcium channel blockers that help the heart beat not quite so hard, not quite so fast. We're managing the tubes. These are going to have some effect on vasoconstriction, but then these are the other kinds of medications that are generally prescribed. The angiotensin converting enzyme inhibitors, these are the ACE inhibitors. And they have that effect that we said, instead of, it interrupts that transition from angiotensin 1 to angiotensin 2 where it gets activated. ACE inhibitors kind of interfere with that conversion. So that decreases the amount of angiotensin, working angiotensin in the system. If the patient can't tolerate an ACE inhibitor, there are ARBs. So it's prils and sartans, angiotensin receptor blockers, the ARBs. These are interfering with the vasoconstriction that is generally caused by the angiotensin. And then, and the other thing it does is because you're interfering with angiotensin, you're also interrupting the release of aldosterone. And I'll remind you, aldosterone is the hormone that causes the kidneys to hold on to the salt, the sodium, because aldosterone is making that sauce. And so aldosterone holding onto the sodium, which would increase the blood pressure by increasing the fluid, increasing the liquid in the tubes. Speaking of liquid in the tubes, we can also address this to help manage somebody's blood pressure with diuretics, allowing the kidneys to release more of the fluid. Of course, there are some side effects. And I'll remind you again, the ACE inhibitors and the ARBs also can impact here because of their interfering with now the release of aldosterone. All right, so that is blood pressure management in a nutshell. And that brings us to the end of chapter 9. Congratulations. Bye.